Assalamu alaikum to everyone. My name is Dr. Ihsanullah, President of Urology Society. Today our topic of my presentation is pre-transplant workup, donor nephrectomy, bench dissection, and recipient search. So we have start. The general assessment. The universal medical goals in kidney donation evaluation process are to ensure that the potential donor has the following characteristics: is sufficiently healthy from both the medical and psychosocial point of view to undergo the surgical procedure, have normal kidney function with minimal future risk for kidney disease, represents negligible risk to the recipient in terms of communicable disease or malignancy transmission, is not at increased risk for medical condition that might require treatment that could endanger his or his residual renal function. The surgical technique for renal transplantation has changed very little from the original pelvic operation described in 1951. The most common approach today is the standard pelvic operation with retroperitoneal placement of kidney, allowing easy access for percutaneous renal biopsy. Usually the right iliac fossa is chosen because of more superficial location of the iliac vein and on this side. The procedure involves two vascular anastomosis, renal artery and renal vein, and the bladder to bladder anastomosis. Come to screening and donor criteria. Any individual who is considered as suitable living kidney donor candidate may undergo a donor nephrectomy. The donor may be either related to the potential recipient or unrelated. For example, spouse, friend, or co-worker. An altruistic donor is a person who wishes to donate a kidney to a stranger. Uh, a number of kidney pair donation KPD program match incompatible donor recipient pairs so that the donor of one pair donate to the recipient of the other pair and vice versa. Kidney donation chain involving multiple donor recipient pairs have also been set up. The counts of KPD transplants in the United States have increased sharply from 27 in 2005 to 42 in 2016. So they appear to have plateaued and now represent about 10% of all donor transplantation. The fundamental philosophy of living kidney donation derives from the Hippocratic oath. First, do not harm. Contraindication to kidney donation may be medical, psychological, social, immunological, anatomical, and ethical.
Just a minute. You go back to this slide, the last one. You see, this whole chapter of donor selection and criteria for selecting a donor and rejecting a donor has to be looked from two different angles. One is the medical angle, and the person has to be psychologically at a stage or of a state that he or she can give informed consent. Informed means that the person who is donating must understand everything related to the medical aspect and the psychological aspect of this donation. The second and the most important things are two. One is social, the other one is the ethical. Now, why I'm telling you is this, because in your very first point of this slide, which says that any individual who is considered a suitable living kidney donor candidate may undergo a donor nephrectomy. The donor may be either related to the potential recipient or unrelated. That is correct, but by means of relation, we mean two things. One is a blood relation, which means the person has to be a brother, sister, donor has to be a brother, sister, or a father or a mother, right? But then you can extend this line of donation to another front, for instance, maybe uncles or aunties and things like that, but it has to be within the family. The other thing is wife. a spouse, a wife or a husband are not blood related, they are emotionally related. So this is another term which is emotionally related. So why we want all these things to be considered? Because one thing, that this is a kind of a practice which has to be, one, voluntary, second, has to be ethically. So if we don't sort of bracket them very closely, these two terms, then we will allow one more thing that can happen anywhere in any part of society, and um, that is exploitation. Now, exploitation may be economical exploitation, which means that you can buy and sell the organ, or it can be in many other ways. For instance, uh, there happens to be a male person in the family, and there is no other person, or there are other persons in the family who can donate the kidney, but the person who is well suited for donation is not the one who can be selected, but it is rather a person who is the weakest of the link. That means maybe there is a sister in the family who happens to be a younger person, but who happens to be again a person who has got no say in affairs related to her. She might be unmarried. So, by all means, medically, she is a very fit donor, but ethically, she is not. So you see, we have to take care of a lot of things which are related to donation, and they might be medically appropriate, but they might not be ethically or socially inappropriate. For instance, this second uh, point in your slide, an altruistic donor is a person who wishes to donate a kidney to a stranger. Now, this has to be something which relates to the society. This has to be something which relates to the understanding of the whole process of the society. So you see, there are a lot of different aspects which are related to donor and donation. It is not simply taking one kidney from a person and just allowing that kidney to go to somewhere, to another person who happens to be a recipient, and nobody knows who is the donor and who is the recipient. This can be managed, this can be done, but you need a lot of maturity in the society, a lot of maturity in executing certain rules, and there has to be the um, the supremacy of law in your society. So I don't think that we as a society has gone on to that stage where we can ensure that this process is without any commercial or otherwise coercions and things like that. So we have to be very much sensitive to all these problems before we go and dive into the topic of donor selection and donor nephrectomy and the whole process of donation. It's not as simple as it looks. It is very difficult, and it has to be done stepwise. So your society has to understand the implications of it. Otherwise, there are many different shades of say again exploitations. So we can talk about this thing maybe in later slides and at the end of our presentation. But just keep it in mind that this is not a simple procedure. It has got many different things at the background. Yes, please continue.
Medical contraindications. Medical contraindications include the following: age. There is no absolute upper age limit. However, donor must be at least 18-year-old. But in Pakistan, we have upper limit 60 years. Hypertension. Blood pressure higher than 140 by 90, or use of anti-hypertensive medication. Obesity. Body mass index greater than 30 to 35 kilogram per meter square. diabetes, or abnormal glucose tolerance test. A history of gestational diabetes or strong family history of diabetes, uh, especially in the first degree relative malignancy, uh, microalbuminuria or poor proteinuria, recurrent kidney stone disease, any kidney disease, low creatinine clearance, GFR less than 7 to 80 ml per minute, any transmissible infection, for example HIV, Hep B, Hep C, any other significant comorbidity, for example cardiac, pulmonary, or autoimmune disease, chronic pain issue and dependence on medication that could negatively affect kidney functions. For example, NSAID. Here is a relative contraindication. Smoking. This is a relative contraindication. Acute substance abuse or using narcotics are also contraindications. Persistent microscopic hematuria in the absence of fever, traumatic menstruation, or vigorous exercise must be appropriately worked up, but is not considered a contraindication for living donor nephrectomy. Psychological and social contraindications include the following. Inactive psychological conditions such as anxiety, depression, or psychosis. If necessary, donor should undergo a psychological assessment as a part of their evaluation. Social barrier to donation. All donors should undergo a social assessment to ensure that no such barrier exists as described in the field. Obvious contraindication should be determined at the beginning of the donor assessment before subjecting unqualified donors to necessary tests. Female patients should not be evaluated while pregnant or planning to become pregnant in the near future. The appropriate postpartum time when donor evaluation may be resumed has not been determined yet, but if the donor so desires, it is reasonable to evaluate for donation after 6 months of postpartum. Desired for future pregnancy does not in general contraindication of donation. Unilateral donor nephrectomy does not increase obstetrical risk or complication or reduce birth rate or incidence of preterm delivery. There is evidence to suggest that live kidney donation increases the risk of gestational hypertension or preeclampsia compared with experience among otherwise similar healthy women. Women of childbearing age should be informed of this risk and supporting evidence. Immunological contraindications include the following. Incompatibility with the recipient. Some centers, however, perform transplant across different blood groups and positive cross match. In such situation, using kidney pair donation and donation chain has enabled more donations. Anatomical contraindications. That includes the following: the presence of solitary kidney or stool kidney. This is an absolute contraindication, the presence of 3 or more renal arteries. Ethical contraindication.
Just a word about this last point. 3 or more renal arteries. I mean, this is not a contraindication. Our own series of transplantation has a lot of those people, not many, but maybe in 2 figures, who have been transplanted and they had more than 3 vessels. If I remember correctly, we had last year done a transplant, maybe 2 transplants where more than 3 and less than 6 arteries were there, either 5 or I think one has got 3, woman has got 6 renal arteries. But there is a way of doing it, and the most important thing that we will see in later slides also, that it depends upon your assessment, your investigation, and your obsession rather of knowing what you are actually confronting with. For instance, what by assessment I mean is to have something called angiography, and these days we have got CT angiography of the donor. Now, whenever we have got CT angiography of the donor, we are very much understood that what kind of uh, anatomy will be there when we go into the process of donor nephrectomy. So this is something called, again, pre-planning. So uh, in many of the centers, this is not a practice, a regular practice, and they always criticize that there is no need of doing angiography prior to donor nephrectomy. But the point which is in favor of doing angiography is simply that you must know in which territory you are actually going. So in surgery, in modern day surgery, there is no such point as going into uncharted territory. So you have to know what are the things that you might or you may encounter when you do surgery. For instance, in this case, we can always select a donor on the basis of something which is close to normality, something which will not affect the whole process of donation. It will not jeopardize the anatomy of the specimen that you take out. For instance, the sole purpose of doing donor nephrectomy is to have a kidney together with its vessels that have to be in good caliber and have got good length, plus a ureter having a blood supply to its upper one third by means of the mesentery that exists between the lower pole of the kidney and the upper part of the ureter. So why I want to have that kind of donor specimen or donor kidney specimen, because when I take this specimen to the bench and I do something for the clearing of certain unwanted tissues, for instance, fat around the vessels. I may dissect a little bit into the renal hilum so that I make the vessel slightly longer in length, so that anastomosis is not only possible, anastomosis in the renal in the recipient, but also it will be easier for the surgeon who is on the recipient side to do it. There is always a disparity of anatomy from where you have taken the kidney and from at which point you are actually transplanting it in the recipient. By disparity of anatomy, I mean that there might be a smaller length vessel that you have dissected, and there is a very deep right or left iliac fossa in which you want to place the kidney. So your hands should go at a point where you can do your surgery easily in the sense that there should not be anything which is rather too loose or too tight, because anastomosis has got certain limitations and certain specifications within which it has to be done. So it's all about adjustment, but it's all about giving the other person. So there might be one person who is doing donor nephrectomy and there might be another person who is doing the recipient surgery. So in order to work in a team, there has always been a place for something giving an advantage to the other person. So for instance, if I'm on the donor side, and if I take out the kidney and there are smaller vessels and I haven't seen the recipient and I'm not of any knowledge what kind of anatomy the recipient has, the person might be thin or might be having say BMI greater than 30. So there are many different variables which have to be considered into this process of taking on one organ from one side and putting it on the other, and one has to give the other colleague the advantage of doing it properly, rather than making his life or her life as a surgeon slightly difficult. So this is a teamwork, and it has to be done with advantage to both. One partner doing it on the donor side, the other one doing it on the recipient side. So please continue.
Ethical contraindications. Ethical contraindication includes the following: financial compensation for organ donation. Any such compensation is prohibited in the United States. The National Organ Transplant Act nota of 1984 states that it shall be unlawful for a person to knowingly require, receive, or otherwise transfer any human organ for valuable consideration or use in human transplantation. So during the evaluation phase, if it is essential to ensure that the donor has not been forced
Right, and
afterwards.
yes, and this point of compensation, this is something which is again debatable. It is something which relates to a particular country, for instance, and a particular society. For instance, this is acceptable financial compensation in Iran, or it is maybe acceptable in certain other countries in the Middle East, but it is not accepted as such in our country, Pakistan. So each country has got its own way of dealing with this kind of situation. Obviously, ours is a different situation, and theirs is a different economical situation, for instance. So we all have to work within the confines of a lot of what I call prejudices. And these are not prejudices in the negative sense, these are prejudices in the positive sense, in the sense that we have to take it all along. For instance, our society is a religious society, no matter how modern we are in our own perspective as individuals, but this is a religious society. And we all have got a lot of traditions along with us. For instance, we might live in north or south or east or west of our country, but we all have got some different kind of communities and community practices. So it is very easy for somebody who is not within the community to criticize the community which is in question. But I think the best way is to take all the reservations along if we want to move forward. Otherwise, we always want to implement something which is in the West in an area which is not West. For instance, in Pakistan, whatever is being done in Japan cannot be implemented here, because there's in Japan it's a different condition. They have got a different kind of philosophy and the philosophy of living their lives. So we have got a different philosophy of living our life. So we have to devise a strategy which applies to our people, our community, our society. And this is the most important thing and the most difficult thing of of all the different aspects of transplantation. So yes, financial compensation might be possible in certain countries and protected by law. In other countries, they are not. Yes, please.
Donor education informed consent. Donor education informed consent. To make an independent and voluntary decision, the donor must be fully informed and mentally competent. The donor must sign a consent from knowledge that the following inform was disclosed to him or her. Reasonable alternative to proposed therapy, the risk and benefit of the procedure, the outcomes for the proposed organ transplant at the particular transplant center. Leaving pre-procedure plan. Leaving donor evaluation requires a brief history and physical examination supplemented by laboratory testing as a prepared medical screening and renal imaging. Donor history or characteristic known to confer significant risk to either the donor or recipient can be automatically precluded donation. There must be a detailed history of any drug the patient is taking to include prescribed and over-the-counter medication and supplement including protein and vitamin. Leaving donor medical evaluation laboratory tests, blood group, HLA typing, cross-match, urinalysis and urine culture, 24-hour urine collection for protein and creatinine vigilance are GFR rate. complete blood count through the mean determination by nuclear medicine test time, partial thromboplastin time. Comprehensive metabolic panel, electrolytes, transaminase level, albumin, bilirubin, calcium, phosphorus, alkane, alkaline phosphatase. Fasting blood glucose, fasting lipid profile, cholesterol, triglyceride. Viral serology is HIV, HB, HC, EBV, cytomegalovirus, herpes virus, and ETY.
And in very near future, we have to include coronavirus in this list of viral serology, because once we settle down from this pandemic, this virus will always be with us in many years to come. And for instance, it took um, the uh, uh, the viral diseases related to chickenpox and others. Uh, I think it's like 2000 years of history. So 2000 years of history, and now we have got a very small um cluster of the disease maybe in Africa that is left behind. The rest of the continent, the rest of the world as such, is now without that kind of disease. So all these viruses, they have to be looked from a different um, time scale, from a different angle of the time scale. So once they are there, they will be for a very long time. So uh, when we start our program again of doing transplant, we have to look into the problem of coronavirus also, in addition to all those viruses that have been mentioned here in this slide. Yes, please.
Uh, Human gonadotropin quantitative pregnancy test involving younger than 55 years. Serum protein electrophoresis in prospective donors older than 60-year-old. Electrocardiogram, chest radiograph, Pap smear test for women, mammography for women 40 years or older, renal imaging, spiral computed tomography, CT angiogram or magnetic resonance angiogram, further testing depending on age, history, abnormal laboratory findings, and family history screening. Colonoscopy if 50-year-old or older, cardiac screening, ECG, nuclear medicine screening test, 24-hour ambulatory blood pressure monitoring, renal biopsy, cystoscopy, PPD skin test, screening for hypercoagulability, glucose tolerance test with the family history of diabetes or risk factor for development of diabetes. And important part of workup is the use of renal imaging studies to ensure that the potential donor retains one normal kidney after nephrectomy. This is the important point. To avoid the blood vessels. To provide guidance for planning a surgical approach to dissection and ligation and circumvent intraoperative implications. This is typically done with the computed tomographic angiography or magnetic resonance angiography (MRI).
Now, just a moment for this slide, the previous one. Yes, the first point, which says that an important part of workup is the use of renal imaging studies to ensure that the potential donor retains one normal kidney after nephrectomy. So if you again refer to the slide in which you have mentioned the age, and you have said that the lowest would be like 18 years and the highest point in your range is like 60 years. Now this is something which is again we have learned in the last 20-25 years or 30 years of our practice, and the whole world has also learned this thing. For instance, earlier it was a practice that we don't accept anyone who is something of maybe 40 years plus. So we don't accept that kind of a person as a donor. And again, we want to have as young a person as possible, so that we will have a kidney which is having all the nephrons working So there are 2 million nephrons, and these 2 million nephrons, if they are working, that has got an advantage. But now, what the slogan was that there is nothing that happens to the donor after donation. What the Americans have done, they have put all their donors on a follow-up, and they have followed them up to like maybe 10 years. And for up to 10 years of post nephrectomy donation of one kidney and the other kidney being normal, they have seen that there is nothing that happens. The GFR remains normal, and the person is active, and there is no other problem. If there is no comorbidity, for instance, the person doesn't develop hypertension in those 10 years, or diabetes mellitus. So if those two things are not there, the person can go along with normal health and a good health. But when they have increased this follow-up period to perhaps 15 years plus, they have seen that there is something which drops down, and what drops down is GFR. So that gives an alarm, a bell ringing, that actually it depends upon the time you follow the donor. And the donor, the older the donor, the earlier the time that the GFR will drop, and the person might need something called reclassification of chronic kidney disease. So a person who has donated the kidney becomes a patient himself or herself if you follow that patient perhaps for 15 years or 20 years on a bigger scale, on a larger scale of population. So that gives us an indication that the donor should not be of maybe 18 years of age, because that person has got, if that person donates a kidney, then that person has to live like another 50 years up to the age of 70 years with one kidney, and that kidney will take the brunt of a lot of problems which are related to maybe hypertrophy of the kidney, maybe injury related to hypofiltration, maybe the person will have got proteinuria in later life. So you have to follow, if you have to follow this patient for 50 years plus, meaning to say from 18 years onwards, then you might see something happening at 15 years, 20 years, 25 years, and the person might land up in renal failure. So this is not a good bargain. So what's a good bargain? The good bargain is something which is in the middle age, something when you have got like maybe 15-20 years ahead of you. So that means that your donor, if that donor is not too young, if that donor is not too old, meaning to say between 30 and 40, so that's an ideal donor. Having cleared from diabetes mellitus and from hypertension, if these two things are not there, the person is or will live a normal life. So now the concept is a little changed, and that change has brought up a lot of sense into the whole process of transplantation. And this is actually what science is. You have to learn from your own mistakes, and then admit them, and then rectify them, and then move along. So this is what the actual thinking is. The body mass index has to be lower, has to be a bit less than 30, maybe between 25 and 30. So GFR, you must calculate it. GFR will drop as the time of follow-up increases. So that's the kind of concept that we have, and it should be there at the back of your mind. So you should not take a person who is like very young, maybe 18-20 years, because again, as I have said earlier on, that person has got a lot of life in front of him or her. Yes, please continue.
Equipment for donor nephrectomy. Equipment, general surgical equipment relevant to both micro-invasive donor nephrectomy and laparoscopic donor nephrectomy. It can include the following: a general and vascular surgical tray with scissors, forceps, needle holders, retractors, scalpels, clamps, and sutures according to the surgeon preference. Device for suction, irrigation, insufflation, and electrocautery. These must be tested and functional. Agent for intraoperative hemostasis, fibrinogen or thrombin products. An ice bath or some other preservation method according to the surgeon's preference. For MDN, defibrillator are employed to expose the retroperitoneal space. Surgical clips for securing hemostasis are associated with an increasing risk of hemorrhage and therefore should not be used. Neither suture or vascular scrapulars are suitable for vessel ligation. For LDN, various needle or Hansen cannula can be used to achieve entry into the peritoneum for insufflation and trocar insertion. The procedure required a pair of 10 mm trocar and a single 5 mm trocar. A camera with a 30-degree lens is needed for visualization. It should be, have a light source and should be wide bag lens. A 15 mm endoscopic specimen bag will facilitate retrieval of the kidney.
Now you see here one point I want to mention. For donor nephrectomy, you can have 3 different ways of doing it. Maybe 2 different ways. One is by open method, open donor nephrectomy. That is in the person is it is on the side, and the incision is the lumbar incision. So that is the open method. The second method is the laparoscopy. Now, what the laparoscopy and the method of doing laparoscopy is employed here in SIUT is a little different. It is a little different from what you can see on this slide. For instance, the lens, starting from the lens that we use is a 0-degree lens. It's not 30-degree, because we have been trained by our seniors of doing it with a 0-degree lens, and we can have it with 30-degree lens, but there is a little bit of adjustment in orientation, and there is an advantage for 0 as well as for 30. With 30, there are a lot of things that you can see which you cannot see from 0 lens. I can give you another lecture if you want to on that aspect, because I have worked in both the platforms. Again, this laparoscopy can be done through 2 different ways. One way that we do here in SIUT is the transperitoneal way. The other way is the retroperitoneal way. And there is another 4th approach, and that is a robotically assisted donor nephrectomy that we haven't done yet in SIUT, but we can always devise that kind of a strategy. So for the time being, if you don't understand any of these things, just understand that there are maybe 3 different ways of doing donor nephrectomy, and it can easily be done. And this is, mind you, a living donor nephrectomy. A cadaveric donor nephrectomy is a different nephrectomy. We can talk about it later also. So we don't do it with, for instance, Verey's needle. We do insufflation by open method, and that is through Hassan's technique. We don't use Hassan's cannula for that matter, but we use Hassan's technique, which is an open technique of accessing the intraperitoneal cavity for insufflation. So all these terms we will come to that again and again when you will be introduced through our lab, which is the skills lab in our unit SIUT, and you will be exposed to all those equipments as well as steps, first on animated objects, then on maybe high fidelity platforms, and then into real patients. So we have got a very stepwise fashion of introducing a person to transplantation rather than to laparoscopy, rather than putting that person directly into laparoscopy. So we'll talk about this thing and the training and other things later also. Yes, please continue.
Procedure timing. Organ procurement is time sensitive and the transplant surgical team should minimize the warm and cold ischemic times. Recommended procurement time limits for optimal organ availability are represented in tabular form in the image below. Acceptable warm and ischemic time of for real allografts. Warm ischemia time for extubation and cessation of circulation to removal of organs and perfusion with cold preservation solution is less than 60 minutes. Cold ischemic time from initiation of cold preservation solution to restoration of warm circulation after transplantation is less than 24 similar and in some articles there is 27 less than 72 hours. The surgeon will probably request that other medication, mannitol or heparin, must be given to the patient just before the vessel to the kidney are clamped in the preparation for removal of kidney. He or she may also request that protamine be given after removal of the kidney to partially reverse the effect of heparin.
You go back to the two slides, the other one, this one. You see these times or these timings of warm ischemia as well as cold ischemia, they are for cadaveric donation. Now, when you do surgery on a living donor, the person has got, for instance, both the procedures, the donation as well as the recipient surgery. They are in two rooms which are very close to each other. So this ischemia time is as short as like 2 minutes. It's not more than that. So 2 minutes is maybe the warm ischemia time, and the cold ischemia time is actually somewhere between 25 to 30 minutes. So if you take into consideration both warm ischemia time and cold ischemia time, we call it total ischemic time. So total ischemic time is not more than maybe 30 minutes. It's within 30 minutes. Why this is important? Because the whole success of the surgical aspect of transplantation depends upon the ischemia time. The longer the ischemia time, the greater will be the acute tubular necrosis, and the longer will the kidney will take to come to normal position of producing urine. So the shorter the time, the greater will be the probability of producing the kidney when you just open up the clamps and the blood flow is restored to the kidney. So you will see all these things and their effects, and it is very interesting. But for the time being, just keep it in mind that if this ischemia time is shorter, there will be a higher success rate, and the kidney will be functioning normally as compared to something which is like this 72 hours or 60 minutes and things like that. So this is for the cadaveric, but for open donor nephrectomy and renal transplantation, living donor renal transplantation, it is very, very minimal in terms of minutes, like 30 minutes. Yes, please.
Microinvasive donor nephrectomy procedure. In preparation for NDN, the donor is placed in the lateral decubitus position with the ipsilateral side up. The operation table is in 30-degree flexion with a 20-degree Trendelenburg tilt. A vacuum activated bean bag or foam padding is used to stabilize the patient and facilitate posterior rotation of the hip for optimal access. A pad is placed to maintain the neck in the neutral position and prevent cervical thoracic vertebral strain. And padding is used at the dependent axilla to prevent brachial plexus injury. The patient properly positioned and ripped, a 6 to 8 centimeter incision is made from the tip of the 10th rib to the edge of the rectus abdominis. The rib is not resected, instead the fascia and muscle layer are split in the line of ear fibers to minimize post-operative pain. this incision is not. Uh, the peritoneum is retracted medially with liver retractor to expose the retroperitoneal space and the kidney. Dissection starts at the ureter, which is separated from retroperitoneal tissues. The periureteric vessel must be preserved to maintain the blood supply to the ureter. The perinephric fascia, fascia is incised and the kidney is mobilized. The arterial and gonadal vein are ligated or cleft with the intravascular stapler and divided. The renal vein is dissected to its junction with the inferior vena cava, and the renal artery is dissected to its origin from the aorta. The ureter is stapled and divided at the point where it crossed the iliac artery, then divided proximally. The patient is given mannitol 25 gram and heparin 5,000 units intravenously and administering mannitol and furosemide before removing the kidney, promotes free radical scavenging and dialysis, respectively, thereby minimizing ischemia, reperfusion injury. The renal artery is divided with the vascular stapler. The author used the Ethicon Profinet TX30V 30 mm reloadable vascular linear staplers, applying it across the renal vein to close the inferior vena cava. The kidney is immediately flushed on the back table in an ice basin with the preservative solution maintained at 4 degrees Celsius. Protamine 25 mg is administered to the donor to partially reverse the heparin effect. Hemostasis is obtained and the wound is closed in layer with the single continuous 2-0 monofilament suture at each muscle layer. A field block is placed using local and regional infiltration of chlorpheniramine 0.25% to reduce post-operative pain. This step shortens the hospital stay with 85% of donor moving home by the next day. Laparoscopic donor nephrectomy procedure. The patient is placed in the modified lateral dectuvation position with the flank at 45-degree angle to the table and the hip rotated posteriorly as described above. The dependent leg is flexed at 40 degree and the upper leg is straight and level with the abdomen. Foam padding is placed between them. The arms are maintained at chest level and both are secured to each lateral side of the table. The table may be flexed at 30 degree to facilitate board placement and usually lowered after a pneumoperitoneum is established. Padding is employed as described above in previous procedure. The left-sided approach to laparoscopic nephrectomy avoids the need for liver retraction and often provide a longer renal artery and vein. Laparoscopic donor nephrectomy, left donor nephrectomy, is performed as pneumoperitoneum is established through either a closed technique with various needle or an open technique with Henderson cannula or hand board. Insufflation of the peritoneum should be maintained at the lowest pressure feasible to enhance renal blood flow intraoperatively. Approximately 10 mm Hg is optimal and pressure exceeding 15 mm Hg should not be avoided. In an obese patient, higher pressure may be needed for insufflation and an open approach may be proved if necessarily needed. The first 10 mm port is placed lateral to the rectus abdominis, approximately one in medial and one in superior to the interior superior iliac spine. The second 10 mm port is placed at the umbilicus and the final port is placed midway between the xiphoid and umbilicus. A right-sided approach necessitates the placement of additional mid-axillary 5 mm port for liver retraction. This is the difference between left and right nephrectomy.
Just a word about just a word about this point of the pressure and flow of carbon dioxide. You see, the gas which is used for insufflation is carbon dioxide, and the surface which which is exposed to this gas, carbon dioxide, is an absorptive surface, the intraperitoneal surface. So whatever is introduced, it will be absorbed by the peritoneal surface and the vessels which are running over them. What happens is, if you increase the pressure uh, beyond 15 millimeters of mercury, what happens is it will on one side be absorbed, and there will be hypercapnia, which can easily be monitored by the anesthetist, and the anesthetist has to do a lot in order to flush away the excess carbon dioxide. Otherwise, the carbon dioxide narcosis effect will happen, and there will be acidemia because of the carbon dioxide being absorbed into the circulation and leading to the alteration in pH. The second thing is the excess pressure will always cause the vessels which you are actually dissecting to go into tamponade, to go into higher pressure, to go into something called pressure on them. So, for instance, if you are doing dissection and there is some bleeding at maybe at the level of a smaller vessel or some capillaries, so what as a surgeon you want to know is something that it has to be in front of you so that you can take care of it. Maybe by means of coagulation, you just take hold of that bleeding point, or maybe you can put a clip over it, because since you are doing an open surgery, it will not be possible to stitch it. Then and there, a stitch can be placed, but it needs a little bit of more time as compared to open surgery when everything is in front of you. So whenever you are doing surgery in a closed compartment as laparoscopy, you have to understand a lot of things, a lot of different parameters. When you do surgery by open technique, now you do an incision, or you put an incision and you open up the space, whether it is laparotomy or retroperitoneal space, you are doing it in the retroperitoneum, but everything is opened up. So there is no pressure effect because there is no closed compartment. But when you do laparoscopy, or when you do, for instance, endoscopy, there is always a closed compartment. So either if you are using some fluid to make your space more wider, then that fluid will be there and it will be absorbed. And if it is a gas which you are using to create the space, then that gas will be absorbed and it will actually produce pressure on certain structures. So it can mislead you, it can misguide you. For instance, if I increase this pressure to 20 millimeters of mercury, it will be absorbed, and again it will cause those smaller bleeding points to just close down. But when I release the pressure, for instance, I just end my procedure, I have to close down my insufflator. Everything which is going into the body will be stopped. The gas will be maybe released out through the ports, or it may remain within the cavity. But in due course, when I transfer the patient to recovery, or maybe into the ward 1 hour or 2 hours or 3 hours later, those smaller points which earlier were under pressure because of high pressure of gas were actually now coming up, meaning to say they will again bleed, and that this is a secondary bleeding, and this is always something which we cannot see. And since we cannot see, this is special to this kind of surgery. So you have to be very careful in adjusting all these things, which make your surgery easier at one point, but it can lead you to or misguide you to another level, and you will be at a loss when you want to follow your patient in the recovery and later in the ward. So This will again we will discuss these points and these finer aspects of surgery, particularly laparoscopy later also. But you all must consider that this is uh, another phase of your learning, since you are learning the steps of surgery. So you have to learn them according to minute details that they are actually presenting with. Otherwise, if you miss these points, they will again be something which will make your understanding of any kind of surgical procedure um, slightly different for each person. So maybe what I am talking is not making sense now, but it will be of interest when you will actually practice these procedures yourself. Yes, please proceed.
A camera is placed in the 10 mm umbilical port, a forceps in the 5 mm port, and the surgical scissors or hook electrode in the other 10 mm port. The lateral border of the peritoneum, including the colorenal ligaments, is bluntly dissected to allow the colon to be reflected medially from the splenic flexure to the sigmoid colon, exposing the perinephric fascia, gerota fascia. The fascia is incised to expose the superior pole of the kidney. Once mobilized, the superior pole can be elevated and facilitate further dissection of gerota fascia to expose the hilum. The renal vein and artery are carefully dissected and divided, along with the gonadal, adrenal, and lumbar veins. The ureter is then dissected inferiorly and ligated at the point where it crosses the iliac artery and vein. The patient is given mannitol and heparin as in the MDSC. An endovascular stapler is used to transit first the renal artery and then the renal vein, thus freeing the kidney from the for removal. The stapler is most effective if it compresses for 5 to 10 seconds before being discharged. These measures allow displacement of third space fluid within the vasculature, reduce the distance that the staple must traverse, and provide greater security at the staple line. A 15 mm endoscopic specimen retrieval bag is advanced through the umbilical port once in place. Its springs open to allow carefully capture of the organ. The bag is then retracted to the abdominal wall, and the umbilical incision is enlarged by approximately 5 cm to facilitate the traumatic removal. The fascia is closed, pneumoperitoneum is re-established, and hemostasis of the renal bed is secured before the closure. Ports should be closed individually with the 1-0 polydiaphragm suture and inspected intra-abdominal for bleeding. Other techniques for nephrectomy. Transvaginal nephrectomy has also been attempted but has not gained widespread acceptance. A few studies have evaluated LDN with vaginal extraction. Incision made through the natural orifice of the vagina are thought to yield better osmosis and less post-operative pain. An endoscopic specimen retrieval bag endocape is used to retrieve the kidney, and episiotomy is made to facilitate this removal. The main point of debate concerning this procedure have to do with the infectious complication of transvaginal removal. The issue is involved in removing large kidneys and the use of nulliparous donors. Robotic donor nephrectomy can also be done and may less laparoscopic MDN in near future. Pinching the kidney from deceased donor. Kidneys from a deceased donor are generally procured with a significant amount of surrounding tissue, including the surrounding perineal fat, the adrenal gland, and portion of the aorta and inferior vena cava. The two kidney may also be procured in block. This wide dissection minimizes the risk of damage to the renal hilum at the time of procurement. Therefore, the first step of deceased donor kidney transplant procedure is to adequately prepare the graft or to render it suitable for transplant. The basic steps involved are inspection of the organ, dissection of the artery and veins, and removal of the surrounding perineal fat. Procedure. The first step of procedure is the kidney is oriented in the anatomical position to allow for careful inspection of the renal artery. You can see in the red arrow. Placing a small clamp on the distal ureter, as mentioned in yellow arrow, is helpful in keeping proper orientation of the kidney. The vessels are inspected for evidence of damage or atherosclerotic disease. The parenchyma should also be inspected for evidence of traumatic injury. The second step, the renal artery is dissected free from surrounding hilar tissue and in appropriate size. The aortic page is present, as you can see in this figure. The third step is the renal vein is then similarly dissected for adequate length. Branching, including the renal, gonadal, and lumbar, all need to be divided and ligated. These branches are usually present on the left renal vein, but the right renal vein usually has no branches. For left kidney, there is usually adequate length so that the inferior vena cava does not need to include, as you can see in this picture. The fourth step is with the right kidney. The right renal vein may be sometimes be short. If so, it can be lengthened by using a segment of inferior vena cava, transiting it transversely superior and inferior to the renal vein, and then closing the edges of the transected inferior vena cava using fine vascular sutures, as you can see in the blue dotted line. The fifth step is surrounding perineal fat is then removed from the kidney, taking care not to injure the capsule. This is started from the medical aspect of the upper pole, where the adrenal gland is identified and removed. The dissection continues along the upper pole and then the lateral aspect of the kidney. You can see in the arrow. Care should be taken not to carry the dissection too extensively in the upper pole, as this may devascularize the ureter. The fat in the triangle formed by the lower pole, the hilar vessel, and the ureter should not be separated from the kidney to preserve blood supply to the ureter, as you can see in this picture. The sixth step, minimal dissection should be done around the ureter, but the accompanying gonadal vein may be removed. The kidney is now ready for implantation.
Now, just a word about this whole 6 steps that you have mentioned. These 6 steps were actually for cadaver organ donation. For instance, when you do have a person who is actually not a living person, then you have got the luxury of dissecting the aorta along with the kidney, as well as you can have the luxury of dissecting the whole vena cava along with the 2 kidneys, and then you can have a lot of patches to remove and make your adjustments and do your lengthening of vessels. But you see, for instance, if you go back to the previous slide and the previous one, yeah, here you see there is a lot of inferior vena cava which is attached to this specimen, the diagrammatic as well as the picture. Now it's up to the surgeon how much length of vessel the person wants. So the excess tissue can easily be dissected out, cut with the scissors, and the vessel can be sutured down so that it has got a very nice caliber to work with the vein. Whenever this kidney is placed in the iliac fossa, and you make use of common iliac vein or the external iliac vein. But if you go back again to the slide, which is slide number, I think, the third point or the second point, the previous one, previous to this, and the other one. One back. Yeah, this one. So you see, there is one thing which is known as the patch of aorta. Now this is known as Carroll's patch. Now Carroll was actually a person who was given Nobel Prize, Alexei Carroll, for the development of sutures for vascular anastomosis and vascular repair. So this Carroll patch, you can always have it when you have got cadaver organ donation. You cannot have this patch of aorta when you do normal living donation, living kidney donation, because your clamp in the living donation will be on the renal artery rather than on the aorta. It will be very difficult to repair aorta, so you cannot just take the piece of aorta in the living condition. What you can have is a piece of inferior vena cava. If you want to take the kidney on the right side, then you place your clamp directly on the inferior vena cava, because a vein is easier to handle by means of anastomosis. For instance, you want to repair the vein, it will be easier done as compared to aorta, which is very difficult to repair. So Carroll patch or the aortic patch is only possible in cadaver organ donation. It is not possible in living condition, in living donation. So this has to be kept in your mind. Whenever you want to do transplant, you want to do donor kidney transplantation, or you are a surgeon on the bench doing bench dissection, the purpose of doing everything should be clear in your mind. For instance, what the person on the bench has to do is to adjust the length as well as the caliber of the vessel, make them clear of anything which is unwanted, meaning to say any tissue, any fat or fatty tissue which is around the vessel, so that your anastomosis should be within between the vessel wall on the two sides, on the recipient side as well as on the donor side or the kidney graft. If this anastomotic line is with this kind of tissue which is fat or any tissue which is other than the vessel wall, then it will be the seat of thrombosis. So these are, for instance, this fat is thrombogenic. So what we don't want after we release the clamp is to have a clot or a thrombus in the space which can actually obstruct this blood flow. And this is the thing which has to be kept in mind very closely. This is not something which can be overlooked, because the whole surgery depends on something called blood circulation and anastomotic line, and we have got no place for thrombosis. So this has to be kept in mind very clearly. So you please proceed.
Adult kidney transplant. The standard kidney transplant for an adult recipient is usually a heterotropic procedure with the kidney placed in the retroperitoneal location, either in the right iliac or left iliac fossa. The right iliac fossa is usually preferred unless future pancreas transplant is planned or the kidney transplant was previously performed in the right fossa. In these cases, the left fossa is chosen. In certain situations, an intraperitoneal placement of kidney may be the better option. If the procedure is performed with a simultaneous pancreas transplant, then the kidney is best placed intraperitoneally on the opposite side of pancreas. In very small pediatric patients, usually less than 20 kg, or in intraperitoneal position usually allow for more space and anastomosis to larger vessel for inflow and outflow. Lastly, in the recipient with multiple previous transplant or with other previous procedure on both right and left iliac vessel, and intraperitoneal lubrication allows one to stay away from the site of previous surgery and use the distal aorta in inferior vena cava for graft implantation if necessary. Regardless of the location of the kidney, for adult recipients, the vascular anastomosis are generally performed to the iliac vessels. For arterial inflow, the common iliac artery, internal iliac artery, or external iliac artery may be used. Generally, the external iliac artery is preferred, but if it is deceased or small in caliber, then there should be no hesitation in using the common iliac artery. Ultimately, the best option is to place the kidney in the fossa prior to the selecting site for the anastomosis, and choose the site where the renal artery will lie most naturally without significant tension, redundancy, prudency, and angulation. The iliac vein is used for venous outflow against most commonly the external iliac vein. However, the optimal site should be chosen based on the position of kidney. The branches of the iliac vein are more variable than the artery. Here may be dominant internal iliac vein or several smaller veins. If the graft renal vein is short or the recipient iliac vein deep, then the branches of the iliac vein may be divided. This allows the main vein to be to brought up into more superficial position, making the anastomosis simpler. Urinary continuity is restored by connecting the transplant ureter to the bladder. This may be done with or without a stent. Several different techniques have been described for performing this anastomosis. The key goals are to ensure that the ureter is not under tension or too redundant, and that is well vascularized and perfused at its most distal portion, where the anastomosis will be performed. It is advisable to create some form of tunnel from distal aspect of the transplant ureter to diminish urinary reflux. The operative procedure. First step is with the patient in the supine position. A hockey stick shaped incision is made in the lower quadrant purple line. You can see the incision starts in the midline, 1 or 2 finger width above the pubic bone. Solid, you can see solid black line. This incision extends laterally, gently curving upward until the lateral edge of rectus muscle is reached. The incision is then extended superiorly along with the lateral edge of rectus abdominis. The second step, the incision is deepened to the fascia, starting medially and going laterally. The anterior sheath of rectus muscle is incised at the lateral edge of the rectus muscle. The fascial incision is carried superiorly just lateral to the edge of rectus muscle. This is where the muscular layers of the lateral abdominal wall starts to form the anterior and posterior sheath of the rectus muscle. Relatively little actual muscle needs to be divided with this approach. Medially, it is usually not necessary to divide the rectus muscle, but mobilizing it down to its attachment to the pubic bone helps in lateral exposure of the bladder. Third step is the inferior epigastric vessel are encountered in the middle to lower portion of the incision. Once the fascia is incised, these vessels are divided between the ligatures, as you can see in broken blue line. The fourth step is as the incision is deepened, the next structure to be encountered is the round ligament in female and spermatic cord in males. The round ligament can be divided, but the spermatic cord should be preserved and a vessel loop passed around it. As You can see in the dotted yellow line. The fifth step is the peritoneum is then gently reflected medially towards the midline, using one hand to retract the peritoneum and the cautery to divide loose connections. This allows visualization of the retroperitoneal space with the underlying source muscle. The sixth step is a self-retaining retractor is inserted at this point. An outline of the iliac vessel can be seen at the base of the wound with the genitofemoral nerve laterally and the native ureter medially. Where the ureter enters the pelvic is a good landmark to locate the bifurcation of the common iliac artery into the internal and external branches. Care should be taken to ensure that the blades of the retractor do not impinge and occlude the iliac vessel proximally. The seventh step is the external iliac artery is dissected free and mobilized for adequate length to allow for subsequent clamp placement and anastomosis. Lymphatics overlying the artery should be carefully ligated to diminish the risk of lymphocyte formation. The eighth step is the external iliac vein, usually lying just medial to the artery, is subsequently isolated. If the iliac vein is deep or the transplant renal vein is short, the internal iliac venous branches can be divided to place the vein in the most superficial position, as we discussed in previous slide. It is usually a good idea once the vascular dissection is finished to place the kidney in the iliac fossa to determine the best location to perform the venous and arterial anastomosis. These locations can be marked with marking open page. You can see open purple line. The ninth step is usually the venous anastomosis is performed first. Clamps are placed proximally and distally on the vein and an appropriate size minectomy is made. There is several ways to perform an actual anastomosis. One technique is to place 4 sutures, as you can see in this picture, one at the upper end and of the anastomosis, one at the lower end, and the one each on the 2 sides, as you can see in this picture. The 10th step, the 4 sutures are tried and the superior stitch is sewn circumferentially around anastomosis, with the primary surgeon suturing his or her side and assisting the other side. In this manner, the renal vein is anastomosed to the iliac vein in the end-to-end anastomosed fashion.
End to side.
Yes, sir. You can see in this picture.
This is not end to end, this is end to side.
Yes, sir. The 11th step, the arterial anastomosis can be performed in similar fashion after clamping the artery and making an appropriate size arteriotomy. If there is no aortic cup present on the artery, as with living donor transplant, then a small circular arteriotomy is made on the iliac vessel. A vascular punch device may be used for this step. The clamp are removed after this anastomosis and the kidney allowed to reperfuse. If there is a patch present around the renal artery, then a straight arteriotomy can be made on the recipient vessels and the patch sewn to the arterial wall. It is shown in this picture. The 13th step. There is several methods to perform the ureter to bladder anastomosis, including the better Politano, lift rigor, and anterior one stitch techniques. The latter 2 techniques are subsequently described. The distal ureter is adequately prepared by trimming to the appropriate length, ligating the accompanying urethral vessels. and stimulating the distal end. As you can see in this picture. The 14th step. The retractors are repositioned and exposed to the bladder. It is helpful to fill the bladder and clamp the urinary catheter at this position. An incision is made through the retrosal muscle, exposing the underlying mucosa, but not going through it. 15 step. The retrosal muscle is then gently separated from the underlying mucosa. This can be done bluntly with gauze. This step is usually for creation of the subsequent tunnel, which will cover the distal part of the ureter. With the lips technique, an incision is made in the bladder mucosa and the distal spatulated end of the ureter is anastomosed for the bladder mucosa using the fine running absorbable sutures. Triangulating the anastomosis is a useful technique here. One suture is placed in the heel and one at each of the two distal corners. The heel stitch is then tied and run toward the top, as you can see in this picture. 17th step. With the interior one stitch techniques, a double-ended suture is placed in the spatulated end of the ureter with the two needles on the inside aspect of the ureter. These two sutures are then brought through the small opening made in the bladder mucosa with the needle resisting the bladder further distally. These sutures are then used to pull the ureter into the bladder. The ureter is then secured to the interior wall of the bladder by tying the interior double stitch. 18th step. With either techniques, the retrosal muscle is then closed over the distal 5 to 6 cm to the transplanted ureter to prevent reflex. The kidney is then placed in position such that there is no angulation or twisting of renal artery or renal vein. The incision is then closed by approximating the fascia using a running or interrupted suture. Wound closure. Wound closure is the final step of the procedure. Closing is done by two-layer repair of abdominal muscle, first transverse and internal oblique, as one layer and then the external oblique muscle. By number 0 loop nylon suture. Using any drain before closure is controversial, but is used. It should be a closed suction drain such as Jackson drain, and every effort should be used that the drain has no compression effect on the renal vasculature and ureters. The exit site also should be accessed for bleeding. Every bleeding site should be accessed and repaired before closure to prevent post-operative hematoma. Refuse causing the end of operation may be the result of platelet dysfunction or heparin overdose and should be managed accordingly by desmopressin and protamine sulfate, respectively. Excess perirenal fat should be removed and the graft should be placed in the retroperitoneally. Cleared pouch parallel with the psoas muscle to prevent compression of the kidney between the abdominal wall and pelvic bone. If the kidney volume is greater than this space or the renal vasculature or ureter is shorter than usual, then compartment syndrome is inevitable in abdominal muscle repaired in the usual manner. In such situation, the renal artery inflow is good, but the outflow will be disturbed because of pressure of the abdominal wall on the renal vein. Renal venous pressure increase and then the graft will be congested and the urine flow will be decreased. If remain unmanaged, this will eventually lead to decreasing renal artery flow and finally to renal artery thrombosis and graft loss. If the surgeon could not reposition the graft in the supravesical area and anchor it into the abdominal wall without vascular kinking, many other options should be tried. One option is to incise the rectus sheath after closing the muscle. Another option is to close the abdominal wall from distal and proximal and let the part with covering the kidney remain unclosed or closed by artificial mesh, which is used for hernia repair. The last option is let abdominal musculature remain completely open and only covered by the skin. The resultant incisional hernia will repair in future, usually 3 months after transplantation. The best treatment of such condition is prevention by matching the size of the donor and recipient, and special attention to the length of the graft musculature and breeder, and also creating the pouch as the first step during the procedure. This is for those who want to conceive a healthy child born to a female transplant recipient 3 years after successful transplant surgery. Thank you.
Thank you very much. Very good. Good effort on your part, Ehsan, as you have again put it in a very easy manner, all those steps that have to be understood. This subject is still some, there are many things that are left. We can talk about them later, but for the time being, it is rather a difficult subject to understand because you are now just starting your understanding of urology. So for the time being, I think this is something which is all that is needed. We will talk about them later also when you go through your rotation in transplantation in your residency. So if there is any point that needs to be clarified by any person.